Welcome to Test Day Panic. No intros, no fluff. We are jumping straight into the critical concepts you need right now for your exam.
Think of this as a high-speed review. We're hitting neurology, critical care, trauma, and pharm. Maximum information, minimum time. Let's go.
Okay, let's start with the basics of neurodecline, movement. You have to know the difference between abducted and adducted.
Right. Abducted is limbs moving away from the body's midline. Adducted is pulling them in toward the core.
And that's fundamental for understanding posturing.
Exactly. Involuntary posturing is a huge sign of a descending head injury. We're focused on two types, decorticate and decerebrate.
Decorticate, I always think cortes, that's flexion, right? Arms pull in toward the core.
Yep. But when that injury progresses down deeper, you get decerebrate posturing.
Which involves the cerebrum, the pons.
And it results in full extension. The arms lock out.
Yeah.
Since that extension drive comes from the pons, which is basically the last stop for major motor function, decerebrate posturing means a much, much more significant injury.
Okay, so let's connect that pressure, that increased ICP, to vitals. What is the single most terrifying vital sign change you'll see?
A big drop in respiratory rate, and with it, a drop in O2 saturation.
Because the pressure is crushing the brainstem.
Exactly. It's compressing the respiratory center itself, the pons and medulla oblongata.
And for infants, the one unique sign we have to know.
Bulging fontanelles, no question.
Yeah.
That's your giveaway before the sutures fuse.
All right, moving to the absolute hallmark of severe IICP, Cushing's triad.
You need all three components. One, hypertension, but specifically with widening pulse pressures.
2 is bradycardia.
And 3 is irregular or reduced respirations.
So let's talk physiology here, because understanding why helps you remember. The brain is ischemic, so the sympathetic nervous system just floods the body with norepinephrine.
Right, to drive that blood pressure up, spikes the systolic BP like crazy.
But then the body's baroreceptors freak out.
They sense that massive pressure surge and slam on the brakes via the vagal system, the parasympathetic system, which forces the heart rate down. That's your bradycardia.
And that fight-high systolic pressure, super slow heart rate, is what creates the widening pulse pressure.
Exactly. With the slow heart rate, there's more time for venous drainage between beats, so the diastolic pressure actually drops or stays the same.
Systolic up, diastolic down, that's the widening.
And the third piece, the irregular breathing, that's just the brainstem getting crushed. Simple as that.
Okay, let's get into the numbers. Cerebral perfusion pressure, CPP.
The formula is non-negotiable. You have to know it.
Yeah.
CPP equals MAP minus ICP, mean arterial pressure minus intracranial pressure.
And the normal values?
Normal ICP is around 0 to 15 milli-AGC. And your target CPP, what keeps the brain happy, is 60 to 80 milli-AGC.
What are the critical thresholds we have to watch for?
If CPP gets too high, say over 150 milli-AGC, it can actually make the IICP worse.
But the more common danger is it dropping too low.
Right? If CPP drops below 50 milli-AGC, you are immediately risking ischemia. You have to keep that brain perfused.
Now, IICP messes with the hypothalamus, which controls ADH. This creates two big fluid balance problems.
First is SIADH. That's an increase in ADH. The patient holds on to fluid, risking fluid volume overload.
Which just makes the brain swelling worse.
Exactly. The opposite is diabetes insipidus, or DI. That's a drop in ADH. The patient is just dumping urine, risking severe fluid volume deficit.
And shock. Okay, what about temperature? Another hypothalamus job.
If the brain ischemia causes a central fever, and this is critical, that fever will not respond to antipyretics like Tylenol.
Why not?
Because the prostaglandins are acting directly on the damaged hypothalamus. It's not a systemic inflammation problem. You have to treat the IACP.
Okay, invasive management, the go-to procedure.
A ventriculostomy drain. It drains CSF, and it monitors ICP.
And the single most important nursing task with that drain.
Keeping the transducer level with the tragus of the ear. If it's not level, your readings are wrong and your drainage is wrong.
What should the CSF look like?
Clear or maybe pale yellow. Never cloudy, which means infection, or pink, red, or brown, which means blood.
Let's do a quick pharmacology review for IICP, the diuretic of choice.
Mannitol. It's an osmotic diuretic, and the key fact is that it cannot cross the blood-brain barrier.
So it stays in the vessels and pulls fluid out of the brain tissue?
Perfectly put. For antihypertensives, we prefer nicardipine.
A calcium channel blocker. Why that one specifically?
It has a greater impact on arteries, so it helps oxygen delivery without causing venous pooling that could raise ICP.
And positioning. So important.
Head of bed has to be elevated to help with drainage.
And even more important.
The head has to be maintained midline. Use towels, whatever you need. You cannot have any compression of the jugular veins.
And we have to tell the patient to avoid anything that spikes pressure.
No Valsalva, no hard coughing, no sneezing. Absolutely forbidden.
All right, let's map out neurological decline by looking at breathing patterns. What do we see first?
Early on, you might see Cheyne-Stokes, that irregular crescendo-decrescendo breathing.
Then as the pressure hits the pons.
You can get hyperventilation. It's an irritation of the respiratory center.
And the end stage.
Clustered or ataxic breathing. That means the respiratory neurons are profoundly disrupted. It's a terminal sign.
But with all these signs, what's still the single most significant assessment finding?
It's still the patient's level of consciousness, or even subtle shifts in personality and judgment. That's your earliest warning.
And cranial nerves? Early on, what do we see?
Unequal pupils. That's a unilateral impairment of cranial nerve D3, the oculomotor nerve. Also, watch for issues with CN, the abducens, which causes double vision.
Then late worsening signs.
Fixed dilated pupils, both of them. That means bilateral failure of CN, a massive neurological emergency.
We should be cautious about some unreliable symptoms, right?
Definitely. A headache is only really significant if it's sudden and extreme, like a thunderclap.
Seizures, bradypnea, those are too general.
Right. And vomiting is only a major red flag if it happens without any nausea beforehand. That's the projectile vomiting we hear about.
So a quick rundown of late symptoms.
You're looking at coma, fixed and dilated pupils, the decorticate or decerebrate posturing, a central fever, and impaired reflexes.
And we need to distinguish between two states of consciousness.
Yes. A persistent vegetative state means zero awareness, though some reflexes might be there.
Versus locked-in syndrome.
Which is terrifying.
Yeah.
The patient is fully conscious and aware, but almost completely paralyzed. It's critical to assess for that.
And we assess LOC with the Glasgow Coma Scale. What's the order of stimuli we use?
You always start with the least invasive. So, sound first, then gentle touch.
If no response, then you move to
Pain, sternal rub, nail bed pressure. And finally, you check for primitive reflexes.
For brain death verification, 3 key tests.
The caloric test, injecting ice water in the ear, the Dulles eye maneuver, and an apnea test to assess the respiratory drive.
Okay, sharp pivot to mass casualty. Triage. 4 categories.
Immediate, which is red, priority 1. These are your life-threatening injuries like shock, a sucking chest wound, pneumothorax.
Then delayed or yellow.
Priority 2. They need help, but they're stable for now. No major bleeding.
Minimal, green, is priority 3.
The walking wounded, sprains, minor cuts, closed fractures.
And the toughest category.
Expectant, black. Priority 4. An unresponsive head injury with no pulse, no breathing. The resources have to go to those who can be saved.
Okay, back to hemodynamics, mean arterial pressure, or MAP.
You need the formula. MAP is the systolic plus 2 times the diastolic, all divided by 3.
And our target.
We want an MAP greater than 60 millimilli Hg to keep the organs perfused.
If it's low, what are the first, simplest things we do?
Drop the head of the bed Trendelenburg and lift the legs, get that blood back to the core.
And the symptoms of low MAP, how do they progress?
Well, it starts with dizziness, lightheadedness.
Well, maybe some nausea, lethargy.
Exactly. Then the skin gets cold, clammy, you get altered mental status, and finally, syncope.
Fainting. So how do you know if giving IV fluids will actually help?
You do the fluid responsiveness test. Put them in Trendelenburg. If their BP improves, they are fluid responsive. They need volume.
And if it doesn't?
They are not fluid responsive. The problem is likely vasodilation, and fluids won't fix it.
So if they're not fluid responsive, we're reaching for vasopressors.
Yep. Drugs like norepinephrine, epinephrine, phenylephrine, vasopressin, they constrict the vessels to increase systemic vascular resistance and raise the BP.
But they come with huge caveats.
Huge. They're vescants. If they extravasate, they cause severe tissue death. So you need 2 IVs, ideally a central line.
And they must be on a continuous IV drip, never push.
Never. If infiltration happens, the antidote is phentolamine, injected subcutaneously around the site.
What are 2 conditions where vasopressors just won't work?
One is acidosis. It blunts the receptors. The other is active hemorrhage.
And if they're actively bleeding?
The pressor isn't the priority. You have to stop the bleeding first. That's always priority 1.
Quick review. 4 basic types of shock.
Septic and anaphylactic are distributive. Massive vasodilation. They need pressors and fluids.
Cardiogenic shock.
That's pump failure. The heart itself is the problem. You have to fix the cardiac issue.
And hypervolemic or hemorrhagic shock.
Priority is always stop the bleeding. Then you replace volume, usually with lactated ringers,
All right, EKG rhythms. What's shockable?
VTAC, VFib, and Torsades de Pointe. Your go-to drugs there are amiodarone or lidocaine.
And the unshockable rhythms.
Systole, the flatline, and PEA, pulseless electrical activity.
And for those, the treatment is?
Epinephrine, and then you hunt for the underlying cause, the H's and T's.
Okay, rapid-fire antidotes. You just have to memorize these. Opioids,
Naloxone,
heparin,
protamine sulfate,
warfarin,
vitamin K,
benzodiazepines,
flumazenil. But be careful, push it too fast and you can cause seizures.
Tylenol overdose,
N-acetylcysteine,
vasopressor infiltration,
phentolamine,
and cyanide poisoning.
hydrocobalamin,
Moving on to trauma complications. Rhabdomyolysis.
caused by severe muscle destruction, like in a crush injury or a big burn.
And the most serious complication we're worried about is?
Acute kidney injury. The myoglobin released from the muscle clogs up the kidneys.
So the labs to watch are creatine kinase and myoglobin.
Yes, and the absolute priority intervention is fluids. Aggressive 5E fluids to flush those kidneys out.
Let's lock in the thermia ranges. Hyperthermia is?
Greater than 103.9 degrees Fahrenheit.
And hypothermia?
Less than 82 degrees Fahrenheit.
Symptoms of hyperthermia.
You'll see high core temp, cramps, sweating, clammy skin, nausea, dizziness, weakness, and a headache.
Hypothermia is slower, more systemic.
Right. You get hypotension, lethargy, reduced reflexes, oliguria, bluish tint to the peripheries, and it can progress to a coma.
Interventions for thermia.
You need internal temperature monitoring, a bladder, esophageal, or rectal probe.
And for hypothermia, the rule is?
Gradual warming only. If you warm them too fast, you risk massive distributive shock.
And we have to remember, burn patients are at a huge risk for hypothermia.
Yes, because of all the evaporative fluid and heat loss. And one last key point. For bradycardia caused by hypothermia, atropine does not work and can be harmful. Just focus on the warming.
Okay, respiratory. Lung sounds. Crackles.
That's a bubbling or popping sound. It means fluid in the alveoli. Okay. Treat with diuretics or antibiotics. The sputum is often pink and frothy.
Raunchy.
That's a snoring sound. Thick sputum in the large airways. N-acetylcysteine can help break it up. The sputum itself will be thick, maybe purulent.
Wheezing.
High-pitched whistling. That's bronchoconstriction. Treat with bronchodilators, steroids.
And the one that means call a code.
Stridor. A crowing sound. That is an emergent upper airway constriction, a true medical emergency.
So for that acute constriction we're using?
Fast-acting bronchodilators, albuterol, Atrovent, racemic epinephrine is a last resort before intubation.
Steroids and antibiotics are for more stable situations.
Right. They don't act fast enough for an emergency.
Quick review of O2 devices. Non-rebreather gives you
100% flow, the highest concentration.
in a nasal cannula maxes out at,
About 6 liters per minute.
and for clearing secretions.
Incentive spirometer helps with expansion. But to break up thick stuff, you want something like a flutter device. It creates pressure to loosen the mucus so the patient can cough it up and out.
All right, toxicology, spider bites, black widow causes,
Toxic symptoms can even cause cerebral edema.
and the brown recluse.
That's cytotoxic. Causes nasty tissue necrosis.
And if you need to give antivenin, what do you ask first?
You have to ask about allergies to horses or sheep, since that's where a lot of antivenin comes from.
Burns, full thickness or 3rd degree. The patient might not report pain.
Because the nerve endings are destroyed. The big risk here is compartment syndrome.
The burned skin loses elasticity and acts like a tourniquet.
Cuts off blood flow, it's an emergency. Burn patients are also at immediate risk for fluid volume deficit. Fluid of choice is lactated ringers.
And electrolytes get crazy.
Immediately, you'll see hyperkalemia from cells bursting. Then later, hyponatremia from third spacing, followed by hypernatremia and hypokalemia from massive diuresis. It's complex.
Initial burn care in the field. What kind of dressing?
Cool, dry, and sterile. Do not use ointment right away.
What if you're applying silver sulfadiazine in the hospital?
Check for a sulfa allergy. Maintain sterility, apply with a sterile glove, and keep it away from the face.
And for any major trauma, you have to ask about their...
Tetanus shot.
Yeah.
Always.
Smoke inhalation. What are the signs?
You might see thick sooty sputum. They'll have both respiratory and lactic acidosis.
And you worry about CO or cyanide poisoning.
Yes, which impairs oxygen use. So look for symptoms like headache, dizziness, visual changes, chest pain.
For CO poisoning, the priority is...
100% oxygen on a non-rebreather mask.
And the antidote for cyanide.
Hydrocobalamin.
Let's finish with some PEDS and safety. Pediatric hydrocephalus. The surgical fix is A.
Ventroperitoneal shunt. It runs from a ventricle in the brain down to the peritoneal cavity to drain the excess CSF,
And parent teaching is all about.
protecting the child from head trauma and watching for signs of IICP, which would mean the shunt is failing. So headache, nausea, LOC changes, pupil changes.
Okay, last section. Safety and forensics. Suspected domestic violence. What's the priority?
Patient safety. You have to ensure a safe discharge plan. Notify the charge nurse, notify the social worker,
And for sexual assault.
notify the charge nurse and a SANE nurse, a sexual assault nurse examiner.
And the evidence guidelines are critical here.
Absolutely. Do not remove clothing, do not clean the patient, do not destroy any evidence until the rape kit is done.
The only exception.
Is if patient stabilization is required. For example, if there's a severe vaginal hemorrhage, you treat that first. Life over limb, life over evidence.
We have covered an incredible amount of critical information from ICP all the way to toxicology.
We did. If there's one theme to take away, it's about progression. The way neurological function declines, from Cheyne-Stokes down to ataxic breathing, that tells you everything about how fast things are going wrong.
So focus on that core formula, CPP equals MAP minus ICP, and let that guide everything else.
Exactly. You connect your fluids, your positioning, your pharmacology. It all links back to that pressure. You know the material. Now go nail it. Good luck.